Welcome. Let's jump right in. We're putting together a practical field guide for one of the most common things you see every single day behind the counter, pediatric asthma. Our goal here is to get you up to speed on the latest guidelines and give you some solid counseling points you can use right away.
So here's our game plan. We'll kick things off with the fundamentals, then get into the really big news, the paradigm shift in controller therapy. From there, we'll look at the key drug classes, make sure we nail down proper device technique, and wrap up with how to troubleshoot when things aren't working and what to do in a crisis.
All right, first things first. We have to build a solid foundation. Really understanding the why, the core definition, and our ultimate goals is what's going to frame every single conversation you have with a parent or caregiver.
Okay, so the Global Initiative for Asthma, GINA, gives us this very specific definition. But let's pull out the two phrases that matter most: chronic airway inflammation and reversible airway obstruction. Remembering this distinction is, well, it's everything. It's the key to understanding the modern approach to treatment, as you're about to see.
When you're talking to a parent, these are your targets. It's not just about stopping a cough or a wheeze, right? It's about letting a kid be a kid. It's about them being able to go to school, play outside, and actually sleep through the night without interruption. And here's a huge one for us: getting that rescue inhaler use down to twice a week or less. That's a real measure of success. Now for what is probably the biggest change to hit asthma care in a long, long time. And this one directly impacts what you're dispensing and how you're counseling, especially for any child over the age of 6. And there it is. This is the big one. The old SABA only, use it when you're wheezing approach. It's out. We are no longer waiting for symptoms to get bad before starting an inhaled corticosteroid. The whole idea now is to get ahead of the problem and treat that underlying inflammation right from the very beginning. What I love about this slide is how clearly it shows the why behind the change. The old way, that was just a temporary fix. It relaxed the muscles around the airway, sure, but it didn't solve anything. The new approach, using an ICS, actually treats the fire, the inflammation that's causing the problem in the first place. And that's how we prevent long-term damage to the airways. So here's the absolute crucial point you have to drive home with parents. An ICS is not a rescue inhaler. It's a preventative shield. You have to stress that it takes consistent daily use, sometimes for a couple of months, to really get that chronic inflammation under control. Getting them to understand this is your #1 key to improving adherence. Okay, let's dive into the specifics of the medications you're handling every single day. We're going to focus on the big red flags and the critical counseling alerts that you absolutely need to have on your radar. This is such a simple, but man, is it a powerful tool. You've got to teach caregivers this rule. If their child is reaching for that blue rescue inhaler more than twice a week to relieve symptoms, that's a sign. It means their asthma is not well controlled and it's time to talk to their doctor. It's a super easy to track warning sign. And this is the urgent escalation of that last point. Over-relying on a SABA isn't just a sign of poor control. It is a marker for an increased risk of death. It's that serious. So when you see those frequent SABA refills coming through, that is a critical moment to intervene and have a conversation. With every single Montelukast prescription that goes out the door, you have to counsel on this boxed warning. You have to tell caregivers to be on the lookout for any changes in their child's mood or behavior. We're talking agitation, aggression, nightmares, depression, and to call their provider immediately if they notice anything at all. Now, when it comes to long-acting beta agonists, or LABAs, the #1 rule is they are never, ever used by themselves for asthma, always with an ICS. They are for long-term control, not for rescue, and for the little ones under 6, this is really specialist territory. Yeah, this table is a great reference for you at the bench, but check this out. Look at the jump in dosing for budesonide. It doubles when a child goes from the 1 to 5 group to the 6 to 11 group. It just highlights how doses might need to change as a child grows. But the real counseling takeaway for parents is that most kids get fantastic control on these pretty low doses, which can be a really reassuring thing to hear for anyone worried about steroid side effects. We can talk about the best drugs in the world all day long, but if that medicine doesn't actually get into the lungs, it's not going to work. It's as simple as that. Improper technique is one of the biggest and most preventable reasons for treatment failure. Look, don't just tell them, show them. Grab a demo device and walk them through these steps. The most common mistakes: People forget to shake the inhaler, and they don't get a good seal with the mask. You have to really emphasize it's one puff into the spacer, and then the child just breathes normally for about 3 to 6 breaths. Here are a few high-yield tips for you. First, reassure parents that an inhaler with a spacer is just as good as a big nebulizer machine. Encourage them to switch from a mask to a mouthpiece around age 4 or 5. It just gets more of the drug where it needs to go. And of course, with every single ICS, you have to preach the rinse and spit rule to prevent thrush. So we've got the right meds and we've got the correct technique. But what do you do when a parent comes to you and says it's still not working? This last section is your troubleshooting guide, how to figure out the real problem and what to advise during a full-blown crisis. When a parent tells you their child's asthma isn't controlled, this is your mental checklist. Is it the technique? Are they actually taking the medicine every day? Are they missing a key trigger, like the family cat or dust mites? You have to ask these questions before anyone jumps to the conclusion that the drug or the dose is wrong.
This is such a powerful way to think about it. An ER visit isn't just some random, unlucky event. It's a clear signal that the entire long-term strategy has broken down somewhere. It really highlights just how valuable your role is in making sure that adherence and technique are on point to prevent these crises from ever happening.
During an actual crisis, the approach gets aggressive, and it's built on these 3 pillars: supplemental oxygen to keep their levels up, high and frequent doses of SABAs to force those airways open, and systemic steroids, like dexamethasone, to quickly stamp out that severe inflammation. So we'll end with this challenge for you to think about. With every single pediatric asthma prescription you fill, what's the one thing you can add to that conversation? Whether it's reinforcing the rinse and spit rule, asking how often they're using their rescue inhaler, or just doing a quick technique check, every interaction is a chance to make a difference. Your expertise is the bridge between that prescription in the bag and a kid who can finally breathe easy.